My name's Aaysha Cader, and today I'm delighted to be joined by Professor Mehdi Shishehbor from University Hospital's Harrington Heart and Vascular Institute, Cleveland, Ohio. And we will be discussing his paper titled 1-Year Outcomes of Transcatheter Arterialization of Deep Veins, the PROMISE-2 and Pooled PROMISE studies, to be published in the upcoming issue of JACC Interventions. Thank you for joining us, Professor Shishehbor.
Thank you for having me.
All right, so we'll start at the beginning. Tell us about the background to this paper, firstly about TADV and the lymph flow system, and also perhaps a little bit about the patient cohorts that you enrolled in these studies.
Well, this was many years of hopelessness in a sense that we knew that about 20–30% of the patients with CLTI, critical limb-threatening ischemia with advanced PAD, had no options. And these were patients that were being told that they need major amputation, below knee or above knee amputation. As you know, in the field of CLTI and vascular disease, there are really two options for patients that are at risk of losing their leg. There is a surgical revascularization option where we bypass patients, and there's endovascular option where we open up the arteries with wires and balloons and stents. This is a cohort of patients that are not candidate for the conventional surgical or endovascular options. And historically, these patients, unfortunately, were being told that they need either major amputation or they need palliative care as part of their wounds and ulcer that had no option for treatment.
Right, and that's really useful because this is a very niche cohort of patients that you enrolled. And what was the main sort of modality of treatment that you studied? Tell us a bit more about what transcatheter arterialization of deep veins involves.
Yeah, so this is very interesting. This is very exciting, to be honest with you, in a sense that we knew that the arteries were very blocked, right? These are 100% blocked arteries. They are heavily calcified. The lesion length is very long, and we just couldn't get through these arteries. And in addition to that, the targets for bypass were non-existent. We call these desert foot, which means that there is no target for you to be able to do a bypass for the patient. So we said, well, what can we do? If the road is blocked and you can't get through it, how can you deal with this? Well, we knew that in the calf and in the tibial area and in the foot, each artery has two beautiful veins that run next to it. So the idea was that prior to the blockage, can you divert the blood flow into the veins, reverse the blood flow, and get oxygenated blood through the venous system in a reverse format into the foot and arterialize the veins, making them become an arterial system. Instead of venous, they become arterial. And by doing so, bring oxygenated blood to the tissue and heal the wounds. And our journey started about a decade ago.
Right. Thank you for explaining that process. Could you tell us a little more now about the main outcomes of interest and also very briefly the main results of these 1-year outcomes of PROMISE-2 as well as the pooled analysis?
Yeah, so as I said here, the journey started about a year ago with PROMISE-1. That was what we call early feasibility study. And as you know, a lot of devices and companies, they start their early feasibility study in other countries. But because this is such an area of need, because so many of these patients undergo major amputation, below knee or above knee amputation, that we started in the United States with PROMISE-1. Once we completed PROMISE-1 as an early feasibility study, we then collaborated with the FDA, and the FDA agreed to allow us to do the IDE trial, and we started with the PROMISE-2. So in this analysis, we did basically two analyses, a primary analysis and a sensitivity analysis. The primary analysis was the 1-year follow-up of the patients enrolled in the PROMISE-2, and the sensitivity analysis was combining the early feasibility study, PROMISE-1, PROMISE-2, and then we had additionally, since then, had done an IDE trial in UK, which was PROMISE-UK. And this was the totality of all the patients that have ever been enrolled in a study with a lymph flow technology to divert the blood from the arteries into the veins and do deep venous arterialization. And it was very exciting because, as you know, we published the 6 months data of this cohort of PROMISE 2, the IDE trial, in the New England Journal of Medicine. And as part of that publication and our data to the FDA, the technology got an FDA approval in October of 2024 and is now commercially available in the United States. So there's already been a lot of progress. However, there were some concerns, just like any publication, any work. There were many people that felt at the time that 6 months was not enough of duration and that we needed longer follow-up to prove that this technology truly led to limb salvage and amputation prevention. So the purpose of this analysis was to show the long-term 1-year data of these cohort of patients to see if the amputation prevention or limb salvage would be persistent, but also to do the sensitivity analysis to see if the data would remain consistent. So we had 81 patients as part of PROMISE 2, 32 patients as part of PROMISE 1, and 24 patients as part of PROMISE UK. And the analysis, basically the result of this study showed that the technique not only was consistent through the 6 months to 1 year, but it was also consistent across the different studies. And collectively, we had a consistent result. So what did we find? We found that we had a 54% amputation-free survival in the PROMISE 2, a 68.7% limb salvage, and a 79% survival as part of PROMISE 2. And then when we did the sensitivity analysis of combining all three studies, we saw that we had 66.1% amputation-free survival, 74.4% limb salvage, and a 88.9, almost 90% survival. Now, you may ask that, well, what's the discrepancy between the amputation-free survival and the limb salvage survival? Well, the limb salvage, to me, is the most important because this technology is really designed to save limbs, to prevent amputation. And that's the limb salvage data. So basically, at 1 year, in the pool analysis, we had almost 75%, to be exact, 74.4% limb salvage rate. And in the PROMISE 2, specifically, we had 68.7% limb salvage rate. Amputation-free survival in our analysis combines both survival and limb salvage, whichever comes first. So if the patient died, but even died with their leg on, still counted as an event under amputation-free survival. That's why there's a discrepancy between the amputation-free survival and the limb salvage rate. So in summary, what we showed, that technically there was a 99% technical success rate in performing this procedure, which is a more advanced procedure, something that we have not done in the past prior to these studies with the limb flow and TADV. Number two, that 3/4 of the patients, we could save their limb when these were patients that were offered no options and they were destined to undergo a major below knee or above knee amputation. There were other data that I'm happy to discuss if you're interested.
That's great. Thank you for that really insightful summary of the results as well as the outcomes of this study. So how do these, I mean, obviously there was consistency across the PROMISE cohorts, but how do these results in terms of outcomes compare with other studies of patients with this particular cohort of no option CLTI patients?
Yeah, so, the reality is that, when we say no option, at least to me, as not only the PI of this trial, but also as an investigator that enrolled patients into this trial, to me, no option means that the patient would be destined for major amputation. Unfortunately, we don't have very robust data in regards to what would medical therapy look for these patients. Remember, these are patients, all of them, who had gangrene or tissue loss and ulcer in their foot. So every single patient in these cohorts of studies were patients that had an ulcer or gangrene. The second thing is that the guidelines give a class 1 recommendation for revascularization for these patients, because the fundamental issue for these patients is blood flow. You don't have blood flow, you cannot heal your wounds. And if you don't heal your wounds, you need amputation. Now, there's a small cohort of patients that, they don't want amputation and they get palliative care. And they may live with an ulcer and the gangrene for 3 months, 4 months, 5 months, maybe even 7 months. That's why I said there was some criticism that the original New England paper was only 6 months. That's why we wanted to get the 1-year data out there to show people that we had consistent and persistent outcome up to 1 year across multiple studies. So I really don't have a good answer for you because we really don't know. We don't know, as far as I'm concerned, many of these patients would have ended up with major amputation. And I'm proud to say that in a cohort of patients that have no option, no conventional options, that 3/4 of them could be saved up to 1 year with the LimFlow technology performing the TADV procedure.
Thank you for that. These are actually very promising results, as aptly named for the study. But what do you see in terms of future frontiers for research in these particular subset of patients?
Yeah, one thing that is important, and you discussed it earlier, is the issue of limb salvage, right? Saving the limbs. Another area that's very important for us in this field is wound healing, right? It's one thing to have your leg, which is nice, but it's another thing that the wounds heal in a timely fashion and that the patients can start having normal life. They don't have to wear surgical shoes. They don't have to be offloading their foot. They can go to work. They don't have to go for wound care every week or every other week. There's a lot of consequences. This is a chronic disease, a chronic condition. People that have CLTI, they have to repeatedly be seen by podiatrists and wound care experts. So the other areas that we pay a lot of attention to in this area, in this field, is wound healing and pain. Another thing that these patients have, even though they have their limb, is pain because they're ischemic. They don't have blood flow. And what we showed in our study is that at 1 year, almost 80% of the patients either had completely healed or significantly healing their wounds. And that was incredible that, we were able to heal at least 55 to 60% of the patients completely healed. And another 35% were almost healing and had no wounds to speak of in the cohort of the patients that we studied. So we're very proud of that because limb salvage is great, but also getting the wounds healed is very important. The other aspect that was very important in this study was pain, as I said. When we started the trial at baseline, the pain score, which we have in the central figure of the manuscript, the pain score had a median score of 6. I'm proud to say that at 6 months, the pain score, the median score was 2, but at 9 months and 1 year, the median score for our cohort of patients was 0. And those are the other aspects of these that are extremely important. Going to the last point, which you mentioned, was that, well, what is in the horizon, what's in the future? Well, obviously, we want this patient, we want this procedure to become standard of care. As I said, it's now FDA approved and is commercially available. We want to make sure that this is available at every center in the United States. We want to make sure that we are selecting the right patients. There is no technology that's perfect for everyone, right? So we want to make sure that we have the right patient selection. We want to make sure that the procedure is done correctly and appropriately in the patients. We want to make sure that we minimize the number of optimization procedures that need to be done. As you saw in the paper, for example, there's a lot of optimization that needed to be done in the first 3 months. But what we showed is that from 3 to 6 months and from 6 months to 1 year, that number exponentially decreased. So we want to learn from that. What are the things that we need to do early on so that we also minimize the number of repeat procedures early on in the first 3 months? So there's a lot of teaching points. This is also a multidisciplinary kind of an approach to care. It's not just a procedure. There are podiatrists that are involved, wound care experts, plastic surgeons, vascular medicine doctor, vascular surgeons, interventional cardiologists. So we want the whole team to be aware of this new approach. The care of these patients is very different than the conventional approach. And we all need to be aware of these nuances of the care related to this procedure so that we can provide the optimal care to these patients and make sure that not only we're saving their limbs, we are healing the wounds and reducing the pain that these patients suffer from.
Thank you very much, Dr. Shishehbor, for breaking down this study in such simple terms in a manner that most of us, even those that don't perform peripheral interventions, would understand. We are very grateful for sharing your insights and expertise. And for those of you listening, you can read the full paper in the upcoming issue of JACC Interventions out on the 14th of July. Thank you, Dr. Shishehbor.
Thank you so much. Thank you.